Morning, everyone. I think it must be morning for you again, right?
It must be afternoon. I think, yeah. He's in
Afternoon?
Switzerland.
Afternoon. Okay.
Yeah.
Okay, okay. Afternoon, yeah.
Time difference is 4.5 hours.
Okay.
And it's absolutely freezing. We have 0 degree day and night. Can you imagine?
Wow. Yeah, one can. Must be really, really crazy outside. But inside it was pretty warm.
Okay.
Yeah.
Thank you, and I look forward.
Thank you. All right. So I think I think it's 7 o'clock. So without further ado, we again thank you once again for joining in to our biweekly sessions. Special thanks to Aigen, Dr. Shefali, I think Dr. Udani also is joining in, and the regular case contributors and the attendees for sending in their cases. We have 9 cases today, all new cases. So the format will be for the new ones who are joining in for the first time. The case will be discussed, the clinical aspects from the fellow or the clinician. The imaging aspects will be discussed by me. Then we'll open the case to the panelists for their suggestions. The chat box is open for your comments, your queries. We'll stick to around 8 to 9 minutes per case. We'll hopefully complete by 8:15 to 8:30 at the latest. So without further ado, we'll start our first case. I think there are sets of cases from Dr. Vivek. So over to you, Dr. Vivek.
Right. Can you hear me?
Yes.
Okay. So this is a 4-month-old baby who had presented to us with a 4-5 days history of acute onset fever. Then he became really irritable, had more of a dystonic posturing, which was treated as tonic seizures, focal dystonic posturing, and head tremor, like a no-no tremor. And on examination, he had a ophthalmoparesis, which you would see more often in a bigger child with Becker-Staph encephalitis, that sort of ophthalmoparesis, with mild ptosis, no facial weakness, normal lower cranial nerves. And at that time, we had a MRI, which you would show later. But after that, we did a CSF, which showed 250 cells, all lymphocytes. Protein was not high, 32. Sugar was normal. There was no history of diarrhea. He was never in altered sensorium in spite of, so it was more of ophthalmoparesis. Pupils were normally reacting. So it was external ophthalmoparesis. Reflexes were brisk. There were no focal deficits. And after the MRI, we gave him intravenous methylprednisolone, following which he improved significantly, and on first follow-up is nearly normal now. So, Nihaal, if you could show the MRI.
Yeah. Okay. So I have the T2
nasopharyngeal PCR for respiratory viruses, which was negative.
Okay. All right. So MRI, I have T2 non-contrast sequences out here, and you can appreciate that there is at least coming down in the thalamic regions. You have these bifocal abnormalities, the T2 hyperintense changes. Also, I could possibly find out here in the periorganic region, the subcortical white matter compared to the contralateral side is slightly hyperintense. So possibly one focus over here. No malformations, no structural abnormalities. So biothalamic lesions along the posterior nuclei extending up to the posterior limb of final capsules on the right side. The brainstem also demonstrates edematous changes. You can see the midbrain is involved, the pons is involved homogeneously, and then we have the diffusion weighted sequences. On diffusion, no signal abnormalities for the diffusion weighted sequences in the lesions which we have seen. Post contrast, there was no enhancement of the abnormalities, especially in the thalami or the brainstem. SWS sequences could not pick up any areas of necrosis or hemorrhage, especially in the thalamic lesions or also in the brainstem. Spectroscopy was done, I think, in the thalamus and the brainstem. It had a mild choline peak, but not very significant. Suggestive of likely inflammatory changes, but nothing very specific out there. A small lactate is also demonstrated, but these are commonly seen in the inflammatory conditions. So based on the imaging findings, the differentials I could think of, if you see the involvement of the brainstem, infective causes was the primary differential which you thought of, especially these viruses which can cause these changes. Demyelination, I think the child is 4 months, might be too early, but can be, sometimes they are seen in some cases over here with around 5 months or 6 months, especially from SRTC, was previously discussed, had MOG positive, but as Dr. Vivek has mentioned, the MOG has come out as negative. So infection is the primary differential they're thinking of, and yeah. And the
Would you
follow-up, as
call
Dr.
it
Vivek,
would you call it rhombencephalitis with the thalamus being also involved by definition? There was no diarrhea.
no, I was just concentrating on the main structure involved. I mean, there is
Right.
definitely inflammatory change of the brainstem. So in terms of probability, since the brainstem is more severely involved, there is rhombencephalitis with additional thalamic changes.
It's just at 4 months such severe involvement. I hadn't seen it before, and did respond because there was no diffusion restriction. So it is more inflammatory, and he responded
Yeah.
really well to steroids.
Yes.
I mean, the
Alright,
other differential diagnosis really to raise, and it's good to kind of discuss it in context with the imaging, with such a young child, we really see if this is within the inflammatory context, then really two group of condition need to be considered. Interferonopathies, I've seen and been involved with the care of a number of very young children that were called meningoencephalitis, very high cells that actually ended up having Aicardi-Gouttier syndrome. And the second group of disorder is the congenital HLH. Some of them can present with only CNS involvement, but at that age group, it would be unusual. So I don't know if there was, any investigations for other systemic conditions within this context. The third thing that I'm just mentioning, but I don't know if there was a cytospin done. So you can very rarely get congenital leukemia and things like this. I mean, it's a very high cell count, 250. I don't know if it's worth repeating. And I agree. I mean, the MRI looks very inflammatory, and the good response and in a sense improvement is also would go against such a bad. If this is any of the if this is a viral infection, the child would have been much more severely affected, and the recovery would have been much worse with 250 cell and in involvement of the brainstem. The child would have been on a ventilator if this was an infection.
Yeah, no, Aicardi, the child is been, so at 4 months you cannot assess the development, but you get the feel when a Aicardi syndrome child comes to you, microcephalic, dystonic tremors.
No, Aicardi-Gouttier syndrome and interferonopathy.
Right, fine. So we can do interferon signatures. Will that help in blood?
Yeah, but I think, in this group, maybe you just want to do the 7 gene for the Aicardi-Gouttier syndrome.
So we can do interferon signatures in the blood. Will
Okay,
that
or
help
the
here?
neopterin. At this age group, you can do CSF neopterin.
Right.
And I think it may be worth repeating the cells
The
with
scan.
the cytosine.
No, but can
in
I
the
make
ideal world, yes. But Yale, in our cultural context and the place we live in, and maybe in your place as well, to do a second lumbar puncture of child who is so well is not easy.
I think if you miss it, I don't know. I think it's depend what you're worried about. I don't know. Let's see what Professor Udani thinks.
I just want to, hi, how are you, Ian? I had a question. I mean, interferonopathies, is this the usual MRI picture?
So
Brain-
I know of a number of patients that I've been involved with that were kind of labeled as ADEM at 4 months. And I said, this is not. I mean, I know you guys had the case. We had a few, but in a way, they present. Also, 250 cell would be very unusual for an ADEM. We see sometimes cells within the MOG, but it's a very young child.
What I meant is,
A lot of cells.
sorry, go on.
Yeah, so very young child with a lot of cells. I would worry this is an interferonopathy.
Okay. I see.
Because in a way, this is not and also the brain involvement, is not it doesn't look like infection. So if we don't think this is infection, we think this is inflammatory, then the age is very atypical and the cell count is very atypical. So I mean, I don't know. I think it's
should we have a follow-up
sorry?
scan just in case?
Oh, okay,
to
sorry.
see if the child is sorry. Would a follow-up scan be helpful because child is clinically recovered, and if it's an Aicardi-Gouttier, then maybe
with the Aicardi-Gouttier they can recover because it comes as episode of So I think
I mean imaging wise.
I think it's depend. I'm always surprised by how quickly you guys can get the genetics. It may be that, if you do the AGS genetics and the HLH genetics and you are happy that you're not dealing with like a congenital leukemia or anything like this with 250 cells, then because I would quite like to repeat the CSF because that cell count is very high, and I would like to see that there's no atypical cells.
So, Yale, you are worried about a monogenic inflammatory disorder, right?
Primarily, but I was
yeah.
just saying that also you can sometimes get caught up in this age group by congenital, you know, by lymphoproliferative, by congenital ALL.
Right, with normal counts, is it? In the blood.
250 cell counts.
In the blood.
No, but in the CSF, yeah, with normal counts in the blood, yeah.
All right, Dr. Shefali, I see you raised your hand. Yeah.
Yeah, I agree. With Yale, it could be interferonopathy. By one point which I want to flag is 250 cells with the normal protein and sugar. So the glucose and the proteins are normal. So I think we need to have a repeat CSF as well, as Yale was saying, because of the discrepancy between that. We should be clear about it, and that is something which was in my mind.
Okay, sure.
And it looks like, yeah, it could be an interferonopathy, yes.
How will that help CSF?
You can do
Because
the
see, it's
neoprene.
250 cells and protein sugar is normal. So, I mean, you usually don't, I mean, something could have been raised, you know, if it was infection, I mean, proteins should have a little bit raised, sugar should have, glucose should have been a bit low. That's what I'm saying, because 250 we are getting, I think in that situation, that's the reason which I personally would be repeating.
And you don't want to miss, you know, an ALL at this age group. You know, I think it's, I don't know. I think the parents need to also kind of, because it's very unusual to have such a high cell count with non-infective MRI picture. You know, child, after you've given them steroids that got better, like I would definitely want to do a cytospin.
So
I totally agree. It's definitely second or third in the differential here, but I think it's nearly unsafe not to do it.
So Yale, you are saying that in congenital leukemia, you can have a presentation with no organomegaly, with normal cell, complete blood count, with just CNS involvement, right?
You can have that sometimes, rarely. I think we had one patient, I remember 6 years ago, I even remember it was 108 cells, but actually, in retrospect, they had those lesions on the skull that we missed, they were called eczema. So when we went back to the child, you know, the child did have that. But I just think I don't think this is the diagnosis here, but I think this is, the ALL is a treatable condition. It's not a diagnosis I would like to miss. I definitely, if I had to pick a diagnosis, this would be very low down the differential. But you have a very young child with such a high CSF count. I don't know if they even done the microscopy. What did they say? Is it only, is it more, what is the microscopy here?
It's mostly lymphocytes, 90% lymphocytes.
90%. And no atypical, they looked under, they're happy that, because you can do a cytospin. I don't know, it's a bit worrying.
Right.
If they're happy, I don't know which lab has done it. I don't know if
yes,
they're happy they didn't see any atypical cells. It's a bit unusual, but I think the most likely diagnosis here is an interferonopathy.
No, I don't.
Although Yahel, you said that 250 is too high, so it's some kind of discrepancy. Why not go back to rather common and simpler things and look for CSF again and then decide?
But I still think that even if this, I agree, I would have repeated the CSF, but I also think that even if the CSF cell count has now normalized after the steroids, you have not ruled out an interferonopathy.
Yeah, still, but the common things are common and very rare things are not so every day.
Yeah, but a 4 months old with this MRI picture and 250 cell in the CSF is not common.
Yeah, but let's look at the CSF again and perhaps MR. Why not say something more simple like a para-infectious condition? This is possible.
4 months old, 4 months old. Para-infectious conditions, you know, is not, I don't think would give you 250 cells, this MRI picture in a 4 months old. We very rarely, we see, I can, you know, I think can, you know, on two hands can describe the number of AIDEM prednisation I've seen, you know, under the age of 1. Very rare. I mean, even you think in this group, how often we had that MOG patient in 5 months, how often do we see AIDEM under the age of a 1-year-old? Very rare.
I'm not saying AIDEM. I'm saying para-infectious in the broad sense.
Para-infectious to give you white matter changes in 250 cells?
Uh,
Can
Let's
it
see
not
what
be a
comes
viral
out.
encephalitis as such?
yeah, I mean, why
We are
not a
getting a lot of
brainstem?
thromboencephalitis.
That's my advice, but I think
I have a
I
question.
think,
Yes, sir.
yeah,
Yes,
Dr.
sir.
So I want to ask you, Vivek, was this patient having fever for a few days, some transaminitis and stuff like that?
Yeah, so just 4 days fever. So no, and there's no history of tuberculosis.
Not tuberculosis, but I was
Right.
thinking of, dengue syndrome, because that's going on right now, and dengue can give brainstem encephalitis. And sometimes in dengue, you do not get diffusion restriction. It may only come up therefore it's like a more of a edema, vasogenic edema kind
Right.
of thing. They improve very fast.
Right.
So,
Dengue, you mean to say dengue?
dengue,
Yeah.
dengue.
Yeah, NS1 was negative in this child. We did it.
But it's something like a dengue-like virus thing, because that
Okay.
can cause
Okay.
thalamus and brainstem. I mean, the other thing which causes thalamus and brainstem is A&E, but obviously the story over here doesn't look like that. It is recovered very fast. And they don't have too many cells. They, in fact, they have no cells.
And they
If-
do have some degree of diffusion restriction, small hemorrhage, sort of,
Exactly. The A&E is out. So I'm
Yeah,
saying the other
yeah.
condition where you get thalamus and brainstem is typically dengue or
Right.
dengue-like illness.
Dr. Vivek, I think just to summarize, I think maybe a repeat scan and LP if possible would be helpful.
Right. Sure.
Yeah. All right. Thank you. Dr. Lokesh, you want to say, I mean, you're saying something? Sorry.
No, I was just thinking because we had a flurry of children with thromboencephalitis. So the clinical features here and that kind of CSF still looks like a viral infection, as Dr. Udani was telling.
Okay.
Yeah,
So I
that's
think
what it appeared to be. That's what it appeared to be.
CSF multiplex PCR from Dr. Jayant.
See, CSF multiplex PCR is a very insensitive test, especially for rhomboencephalitis viruses, enterovirus, 20% sensitivity. They don't really pick up much except for herpes, HSV1. Otherwise, it gives you really odd results or no results. So I'm not
Have
sure
you done
it
the
works.
biofire?
But this is not like an infection, common bacterial infection. So
In the
biofire
sense, probably we need
has
to.
common infections and HSV1.
No, biofire can have all the viral panel. We have biofire with all the viral panel. So I was just wondering about the
Now,
viral
the
panel.
sensitivity of it is for this kind of things are low, as Vivek mentioned, Dr. Shifali.
Yeah,
Only thing
I
is we might
agree.
look at the respiratory secretions or sometimes the stools to pick up the organism. Because many of these things like adenoviruses are giving a lot of brain lesions, but you pick up only in the respiratory secretions rather than the CSF. So I think we will have to look at the sensitivity.
Yeah, if you have to do it, better do which we did in this child, and nasopharyngeal PCR was negative, rather than a CSF PCR, which has a better yield for these sort of picture, this sort of picture.
I think we'll move on to the next case. Thank you.
Yeah, thank you. All right, Dr. Vivek, go to you.
So this is a much simpler case. It's I was not even sure if I should put it here, but I thought I will. So it's a 2-month-old baby, just an episode of bilateral tonic seizure, 2 episodes in a day, admitted in a hospital, and was just sent to me once for for assessment. There were multiple Kefil spots already on his body. Nobody else in the family was affected. He looks normal for 2-month age. He had an MRI done, which has been reported as normal. Just some findings which I'd asked Nihaal to have a look. Can it be seen with early NF1 or rasopathy? I thought his centrum semio will look more hyperintense than normal.
All right. So T2 axials here of a
And
2-month
corpus
child.
callosum.
So, I mean, the white matter is unmyelinated, so it will be a little difficult to appreciate the typical focal altered signal changes for NF1 related change. But I think your question was the frontal white matter and the centrum semioval, is it slightly brighter than the rest? But for a 2-month-old, I think radiologically might be a little difficult to say that, Dr. Vivek. There was some asymmetry of the ventricles. The left is slightly more prominent. And the question was of the corpus callosum. There is some degree of thinning of the corpus callosum. I have control images in the subsequent slides. And the posterior callosum, though does not myelinate up to 3 months of age, there is some drooping. If you see the splenium is slightly down. but no structural malformations per se, and no focal lesions. I couldn't appreciate the focal lesions. T1s again, nothing stands out. SWI again, no off-signal changes. Diffusion again, no abnormalities on diffusion. So this is the case, and I got this is the case.
Second image, top second, this
I know. So that is the control which I've taken from one of our cases. For 2-month-old, this is how the white matter should look like. Sometimes the shading can adjust. I mean, the white matter can appear slightly brighter than the rest. But if you can see, there is some degree of hyperintensity in comparison to at least our case, which is a 2-month-old, the frontal white matter. And the corpus callosum, it changes, the thickness changes as the child myelinate. So this is again a case, the control of a 2-month-old. And you can see in our case, the 2-month-old, the corpus callosum is slightly thin. There is drooping of the posterior sphenium. So it is abnormal, but I'm not able to point out the abnormality, specific abnormality based on those findings. The cafe molecule, as you have says, the rasopathies, again, I haven't seen such an early presentation of NF1 or any of these. And the images, I don't think, are very diagnostic to point out any of these possibilities with cafe macules. I'll open the case if anyone has any further suggestions here.
Yeah, I have a short comment. I'm not impressed by this MR. I think it's still in the range of normal for 2 months. I'm not impressed by the shape of the corpus callosum. This MR is neither proving nor disproving NF1, if this is the question, and you will rely on follow-up. You do genetic testing if you want. It has no immediate consequence, and the diagnostic yield is not 100%. So my tendency would be to careful wait and see.
Sure.
So maybe closer to 1 year of age, Dr. Vivek, if the child is relatively stable and no other lesions externally, that will be ideal time, I think.
Well, in the meantime, you may have other NF signs like flickering. Yeah. The child is too young to look for lesion nodules, iris hamartomas.
Yeah. Thanks.
Okay. If there are no further comments, we'll go on to our next case.
Dr. Udani had raised his hands.
Sorry, Dr. Udani. Yeah.
Sorry, I had forgotten to
Okay. All right. Yeah, Dr.
Yeah, so this patient's MRI was a real surprise. So 23-day-old baby, normal birth, no perinatal issues, came to us with a history of 3 days of irritability, tonic posturing multiple times, undocumented fever, was given phenobarbital outside for his tonic posturing, became encephalopathic and had to be ventilated. His phenobarb levels were in the toxic range. CSF was completely normal. His infection markers are normal, and he had this MRI.
Any cranial neuropathies, Dr. Vivek? You know why I'm asking
you that. No cranial neuropathy. Pupils are normally reacting, and fontanelle is normal, and reflexes normally elicited, and normal eye movement.
Okay, all right. Then coming to the MRI. And yeah, this is the MRI over here, and you can see again another brainstem lesion. But here it is more expansile. It's involving almost the entire brainstem, predominantly in the pons and the medulla, with extra pontine involvement. So this is a non-contrast T2. You can appreciate the lesion over here. A non-contrast there is slightly hyperintense. Again, expanding the brainstem structures. Axial T2 sequences, you can appreciate the anterior-posterior and the transverse extension of the pontine lesion going up to the white matter structures in the cerebellum. And SWI and DWI did not demonstrate any abnormalities, no necrosis hemorrhage. Post-contrast, there was no enhancement. Thalamus, again, did not demonstrate any signal changes or abnormalities, which can be seen with these lesions. So based on this MRI, I think spectroscopy was done. Yes, spectroscopy demonstrated significantly elevated choline peak, and rest of the peaks were significantly reduced. Based on the MRI findings, I think we're thinking of the likely possibility of a diffuse midline glioma that is related to the H3K27 altered mutation. There are various subtypes, but the imaging does not help in identifying the subtype. The only thing which I pointed out is the EGFR mutation can have thalamic involvement, but this is not very gold standard. Just to point out the prognosis of this child, if it is a diffuse pontine glioma, the more lateral extension has the worst prognosis than the craniocaudal extension. These are from patients from St. Jude's, around 125 patients. Then we looked at cases for congenital or neonatal brainstem gliomas, and I could find at least 3 case reports with neonatal brainstem gliomas. And what they found was the favorable prognostic factors were if the child was less than 3 years, duration was more than 3 months, and again, absence of cranial palsies, significant reduction of steroids, and the alterations of the H3.1. That is the primary diagnosis I'm thinking of. I don't have any alternate possibilities, so I'll open the case for any further discussion. And if anyone has seen a neonatal child with the DIPGs. Child is 23 days. I think that's the question on the chat. ATRT has been mentioned in the chat. Usually it is slightly more, you have abnormalities on the DWI, SWI sequences, slightly more defined. So I would put glioma as the first differential. I think someone has asked in the chat. Yeah.
It's good to know you mentioned about steroids because we didn't give anything. We're just hesitant. 23-day-old, is there much to achieve? So, but we'll give it.
I had a question. Sometimes in NF1, you get these lesions in the brainstem which are gliomas. Is this any possibility?
Yeah, sorry.
Can I jump in? In NF1, you have, as you know, about 15% of patients have an optic pathway glioma, and about 3 to 4 to 5% have brainstem enlargement, but usually almost asymptomatic. This does not fit.
Right now, of course, it's asymptomatic. So the question is whether this is a, midline gliomas quite, it's a very odd age for a midline glioma to come up.
So Dr. Udani, I've checked, I think at least 3 or 4 cases. I agree it's an odd age, very early predisposition, but there are cases with midline gliomas. I think that's why I think Dr. Vivek wanted to show the case.
Oh, thank you.
And it is actually reported as, young as 4 days.
Yes,
4
yes.
days neonate also it has been reported. So I think
so the middle image is the 4-day one, Dr. Shefali, I think you're mentioning.
Okay.
Yeah.
Okay.
So yeah, the presentation is typical in terms of the imaging, but the age is slightly atypical. And that was a surprise on imaging, I think. Dr. Vivek, if you want to just summarize.
Yeah, it was a surprise.
Yeah.
Because, yeah.
All right. Biopsy, I think there's a question of biopsy. They usually don't get biopsied. Any plan for biopsies, Dr. Vivek? I mean, I think the neurosurgeons don't biopsy these lesions, given that multiple important cranial nerves and other structures are involved.
Yeah, it's going to be difficult to biopsy this.
I don't think a biopsy is required. I think a glioma is, I think we would just go ahead with the glioma diagnosis. Maybe a genetic can help, but I don't think, again, that might help in the diagnosis.
Yeah.
All right. Thank you. All right. From Jaipur back to Hyderabad, Anas, if you're there, or Dr. Karthik.
So this is a case of a 1 year, 4 months old male child born to third-degree consanguineous parents. It was a full-term child, perinatal, no perinatal issues. Child was apparently asymptomatic till 13 months of life, thriving well. After that, he had recurrent URTIs and ear infections, initially unilateral, then bilateral, for which he was shown to multiple ENTs. At 15 months of age, he had cough, cold, noisy breathing, and then which progressed to difficulty breathing for 2 weeks. This gradually worsening of sensorium and motor activities and drooping of eyelids, which parents were reported, but there's no variation in the diurnal variation in the symptoms. As he was persistently dull and child was becoming very sleepy, he was admitted twice to the referral hospital, where he was there initially first admission for 10 days for for which he was evaluated. And as part of the evaluation, he had examination. He had abdominal distension, which was thought to be they suspected could be a part of a syndrome, and he could have exocrine pancreas insufficiency was suspected. He was started on crayon supplement, and his encephalopathy did not improve, but fever and respiratory distress had improved, so he discharged. Few days later, he again presented with worsening sensorium again, and he had CO2 retention, for which he was intubated. Child was the multiple attempts were made to extubate him, but all were made with when as soon as they would extubate him, he would have CO2 narcosis, for which he was continued on the ventilation. So he was referred to Rinbo Hospital for further evaluation. This is when we saw him. Next slide.
No, so Anas, I just want to stop you. There are 2 scans. So when was the first scan done in terms of the clinical presentation, and the second scan, if you have an idea of it?
Yeah, the first scan was done maybe after when he initially presented to the referral hospital, maybe on 25th of November.
Okay. So this the second slide is after the first scan, or?
Yes, sir. Yes, sir. Yes, sir. It's
okay.
after.
Okay. So we'll have a look at the scan first. All right. So we have 2 scans. I think 4 weeks apart. This is on November 2023, and we have the diffusion and T280 sequences. On top, no signal changes on the diffusion-weighted sequence. In the T280 sequence, you can appreciate generalized reduction in the supratentorial brain volume. Yeah, supratentorial, no focal lesions out here. No structural abnormalities. Posterior fossa appears relatively spare in terms of the volume changes, maybe some degree of prominence of the folial space in the vermis. On the T280 sequences, you can appreciate again the supratentorial volume loss, the corpus callosum volume loss, some degree of vermin atrophy, but no focal lesions. The suprasellar pituitary gland also demonstrated normal appearance. I think, yeah, after that, Tanas, you can just highlight the main clinical points.
Reason for at this point of time, there was earlier sibling death as well, early sibling death because of recurrent URTI and LRTI infections. Child was genetics were done for him, and ciliopathy was suspected in him. So when he was examined, he had sparse lustreless hair, broad forehead, stubby nose. He had a dry scalp. He had so he was quite emaciated when you saw him. Weight and length were both less than percentile. He was encephalopathic. His pupils were reactive. There was ptosis, 5 mm interpalpable fissure. Extraocular movements and passive range motion was fine. There's intercostal weakness. He was moving limbs against gravity. DDR were elicitable. So one possibility, there were at that point of time 2 clinical thoughts were there. It could be a central hypoventilation syndrome versus maybe congenital myasthenic syndrome. So a trial of neostigmine was given, and there was no improvement. And in view of financial constraint, the family was referred back. The child was referred back to the referral center, where he continued to have this encephalopathy and CO2 narcosis. Then the new thing that he developed was polyuria and hypernatremia. For these things, they suspected central diabetic encephalitis, and second scan was done on 25th of December.
Okay.
This is almost 4 weeks.
Yeah. So 4 weeks later, there were some areas of distributed diffusion in the hippocampus, especially on the left side. You can see out here. Other than that, I could not find any changes on diffusion. The volume loss has progressed in terms of the prior study. If you compare that to our study here, you can see the sulcus space are more prominent now. Again, no focal abnormalities in the supraperipherally, but if you see along the median thalami, it appreciated along the flare sequences on the subsequent slide. So the flare sequence, you can see that the median thalamic has these hyperintensities going up to the hypothalamus, the optic tracts, the mammillary bodies have these new changes of T2 and flare hyperintensities, which are not there on the previous study. Post contrast, we did not see any significant enhancement. Again, the stellar structures, supracellular structures did not demonstrate any significant enhancement. So interval change of atrophy and these central hyperintense changes were seen on the follow-up scan. based on that, the radiological differentials were located to the hypothalamic regions. So we thought of a possible inflammatory condition or an encephalitis-related disorder. These were the differentials given, primarily the histiocytic related disorders, but the only odd point was the pituitary gland, the stalk was not involved. So commonly seen in these spectrum. HLH was another consideration, given that the child had not improved in between. And then the child had, I think, a bone marrow biopsy. Anas, if you want to just highlight the changes.
Actually, but the markers were changed were negative. And then eventually the child sensorium and the multi-organ, he had multi-organ failure, and parents did not want to continue care further. So child had succumbed, I think, maybe a week earlier.
Okay.
So there's no conclusive answer. LCH was considered, but
yeah. The only thing is the gene which was detected was a variant of uncertain significance, but did the child have any clinical features matching Netherton syndrome? That is
nothing, sir. We looked for it. It was no features were matched. Actually, the
imaging by
yes.
Sorry.
Yes. No. Only the thing is, based on this thing, they suspected they started pancreatic supplements, but other features were not a match.
And any immunodeficiency workup, IgGs and primary immunodeficiency?
We considered even those were negative, whatever was done.
The genetic testing on both the children, first child and second child, they were negative. Looking for the myasthenic syndromes, immunodeficiencies, and all the other things. So we don't have a conclusive diagnosis, and 2 children died early.
Yeah.
So,
yeah.
Is it possible a mitochondrial age-like disease? Failure to thrive,
I think biotin and we had suggested more of a
hypopnea or something of that sort. So CSF lactate, ammonia was, CSF lactate was done.
Dr. Rani, we had suggested the thiamine variant because the structures involved were more thiamine sensitive regions. I think mitochondrial was not tested or CSF done, but I think thiamine deficiency or related abnormalities or another consideration. But the child did not improve on supplementation. I think I think thiamine supplementation or the
improve.
Yeah.
And the mitochondrial nuclear and mitochondrial genome sequencing were looked into, and they were negative, Rajesh.
Yeah.
I know, but the problem is that mitochondrial genome, the nuclei also are about 50% positive and 50% negative.
Yield is very low. Agree.
Yeah.
Very true.
My other question was, how old is this patient?
15 months.
15 months. It's too young, because we had seen a patient who had NMO coming with the similar kind of thing. Of course, she was a much older child, 4 or 5 years.
Okay.
There was anemia, and even the TLC was on the lower side, if you notice. And this reactive thrombocytosis actually 50. So what to make out of that? That is what to be kept in mind with your pancreatic insufficiency. But the child was not malnourished. Was malnourished, right?
Was
malnourished. So that thiamine deficiency, and then so that anyway, you anyway gave that thing. But keeping these 2 cell lines low, so any of these, you can think of something else because of that.
Yeah, bone marrow didn't give
Bone
any
marrow
information.
depletion,
That didn't give a diagnosis to any particulars.
That's right. Yeah.
And genetics of both the children done independently, whole exome sequencing, mitochondrial were negative. So we still didn't have an answer. Any toxins that would be possible?
Usually diffusion, they usually present for any toxic changes of location.
Okay, sure. Thank you. We can move on to next case then. Thank you.
Just once again, location, the other child also, the MRI was similar?
No, that child's MRI, he died very young. His MRI was not showing any changes. Actually, even this child, the first MRI was normal. Normal in the
next
sense,
one.
Normal in the sense, there's some atrophy, but Okay, there are no comments.
So radiology, like mitochondria, the possibility.
CSF wasn't done, no?
Not for lactate, sir. That I know. Lactate was done, serum lactate, but CSF lactate, I don't think it was.
Anas, this
structure-
HB and TLC, which was low, they must have done multiple times, not only
Yes,
once.
ma'am.
Do you
Yes,
have
ma'am.
any?
Yes. Yeah, the previous hemoglobin when he was, I think when initially they're evaluating him for this cough cold and all, at that time his hemoglobin was 9.8 something like that. WBC and platelets were fine. So he was started on Hemantics, but these hemoglobin is that of a recent one, but earlier he did not have any leukopenias. Only anemia was there, like microcytic hypochromic anemia.
Thank you.
The primary immunodeficiency would have been picked up on the genetics, the CVIDs or the.
We gave them history-wise. We asked them to look for immunodeficiency as well after for the reanalysis, but nothing showed up in that.
All right. Yeah, I don't think we have a diagnosis. All right. Okay. So no further comments. Yeah, Anas, we'll move on to our next case then.
Yes. So this is about an 8-year-old male child, born to non-consanguineous parents, uneventful birth and parental history. He was developed fine pre-morbidly. He had fever for 5 days, no history of cough, cold, or loose stools. Interfebrile period, the check was fine. So he presented to us on day 5 of illness. He had seizure in the form of, witnessed by the parents, in the form of uprolling of eyeballs and tonic posturing, which lasted 5 minutes. Following the episode, he did not recover his sensorium. He was not able to recognize them. There's no spontaneous eye opening. When he was brought to the ER, he was still encephalopathic. Pupils were reactive. Eye extracranial were full, but he had developed spasticity with brisk knee and ankle reflexes. He, in view of post GCS, he was intubated in the ER and admitted. A CT scan was done initially, which showed diffuse cerebral edema. And at that point of time, he was started on cerebral edema measures. Then at that point of time, because of the history of fever initially in the background, infective as well as demyelinating, both possibilities were considered, and MRI was done.
Okay.
The first, yeah. This is the first time.
So okay, I have only one MRI. So
yeah, the
all right,
only MRI.
All right. All right. So T2 non-contrast, you can appreciate the multifocal confluent abnormalities involving the white matter structure, predominantly the white matter structures, bilateral hemispheres, also the deep brain nuclei, the central white matter, the posterior limbs out there, the corpus callosum is involved, brainstem involvement is seen, and also the cerebellar white matter, the middle cerebral peduncles have these multifocal hyperintense changes. Similarly, more pronounced, pronounced on the flare sequences, you have these confluent like demyelinating kind of lesions in the bilateral hemispheres, predominant white matter involvement, again central gray matter involvement, and brainstem and cerebellar involvement. It's a non-contrast player, zoomed in image of the optic nerves. You can appreciate some edematous changes in the interorbital segments of the bilateral optic nerves. Diffusion did not demonstrate any changes on the, at least no significant hyperintense changes. There was some T2 shading out here. This did not reverse on the ADC sequences. The SWA sequences do not demonstrate any hemorrhage or calcification or mineralization. Post-contrast, no significant enhancement in any of the interparenchymal abnormalities or the optic nerve. Sagittal's spine was done, which demonstrated long segment, predominantly central cord myelopathy, extending from the cervicomealy junction up to the lumbar spine. So based on these features, I think demyelination is the prime consideration, and based on that, MOG antibody is the most likely possibility on the imaging findings. Optic neuritis, multifocal lesions, confluent lesions, and long segment myelopathy. And our case resembles some of these images, which was from the consortium from the European group, at least the lower panel, this image out here, and the multifocal abnormalities on the right, on the top over there. So I think MOG antibody was the primary consideration. Yeah, Anas, if you want to ask.
Yes, analysis showed 35 cells, and protein and sugars were fine. So IL-6 was sent as well. He was started on immunomodulation for injection methylprednisolone and tocilizumab was considered in view of. So here, so this was done on day 3, and by day 4 itself, he started to have absent brainstem reflexes. He started to develop anisocoria, and then when we had done CT, it showed diffuse cerebral edema. White cerebellum sign was there, and then he started to have central DI. We tried to resuscitate, but the child did not make it as well.
I think the main question. Yeah.
Yeah.
Sorry. Go ahead.
Yeah. So later got the MOG report which was sent, and we had sent MOG and as well as GFAP protein, and we got follow-up. We got the MOG strongly positive. Main query was what could have been done presentation was quite severe. Usually the MOG we are saying they quite respond well to immunomodulation, but this presented very acutely and had very rapid deterioration. We didn't get any time to. We were considering plasmapheresis, but the child deteriorated well in advance.
So, Nihaal, if you remember, a few months back, we had another patient we presented, fulminant MOG.
Yes.
The story was exactly the same. The child came to our hospital, day 1, just expressive dysphasia, and over the next 48 hours, he deteriorated. He was noted to have anisocoria at 8 a.m. We got a CT at 10, which showed diffuse cerebral edema within 2 days of admission. And we were so confused whether we go ahead and do something. And we did by 2 p.m. bilateral frontotemporal craniectomy. And we saved the child. And so he had anisocoria, normal one pupil, the other one was dilated. So we thought whether with this cerebral edema, should we just counsel the family or do something? He had started to just develop polyuria over the few hours. And the child is in follow-up in the last 3 months. His bones have been put back. He's 80% back to normal.
So surgical intervention in terms of craniotomy
So
would have.
very rapid intervention. I was so confused. When I had asked, I remember talking to people. Actually, I rang Lokesh that day. That if I don't know if Lokesh remembers that should I do a frontotemporal craniectomy bilateral because he has diffuse cerebral edema, and sort of so. But we went ahead and did it.
There is some benefit in giving anti-IL-6 in these patients. I think it's a limited benefit, but we do know that the IL-6 in MOG in the CSF a lot of the time is raised. But I think mainly the Americans have been giving it to these cases with diffuse cerebral edema. We have not done it frequently.
But this IL-6 is normal actually. So was it done in the CSF?
Which is interesting. No, CSF.
No,
did you do IL-6 in the CSF?
I think we did CSF, that was in serum. Nobody does CSF IL-6 in India.
No, CSF IL-6 is done. We do it regularly in Jaipur.
Is it?
Okay, and was it normal in this case? Was it normal?
No, we did a serum IL-6 and that was normal.
Yeah,
but I don't know about the serum. I'm talking about the CSF IL-6. That a lot of the time in these AID and MOG with they could be positive, they could be very high.
But we did go ahead and give tocilizumab because of rapid worsening.
You did? Oh, okay.
Yeah,
fine.
we did.
Yeah,
We did
okay.
give 8 milligram per kg.
Okay.
We did give 8 milligram per kg.
Okay, sorry, I missed that. Yeah. And do you think he helped?
No, it didn't help. It just progressed, and we were in double mind whether to do anything because he had already developed diabetes insipidus, and then whether we should go for plasmapheresis for whatever benefit was. We are not sure in this sort of situation where the cerebral edema was already established.
Your patient has a cerebral edema, so we're not talking about immunomod. We are trying to save his life. So tocilizumab takes 2 to 3 days, 4-5 days to work.
Yeah, that's
Plasmapheresis will take 5 days. What you have to think of is a neurosurgical intervention. We are trying to save his life.
Yeah.
Yeah,
Yeah,
Vivek is right.
I
We have
agree.
also had some fulminant
Uh,
ones, and we had to do decompressive crenectomy that time to save their life. It has happened, and we are seeing such fulminant cases occasionally. Yes.
No, I think
And
then
Professor
next phase
Udani,
we
when
should
you had a
definitely,
case like this, would you do both? So as in, would you do the craniotomy and then give tocilizumab and like? I mean, I don't know. I feel like you don't really have time to wait for all the different things to work, no? Or
Yeah.
what have you done in your case?
I think
Yeah.
main thing is that over here, I think Vivek did the right thing, because basically our main issue over here is the cerebral edema. We have seen one patient who had two large areas of tubifactive demyelination, where we did because she also went down very fast, very rapidly expanding, and we actually did a decompression and it's fine now. But the point is that any demyelination, if it is rapid, can give us to massive edema. I think that's what Vivek tackled first. About tocilizumab, I really have no experience, but frankly, we did the IL-6 in Bombay, CSF, the Tata Institute with the friends of place. They do it. It's quite reasonable cost also, about 8,000 for all the interviews. But unfortunately, whenever we've thought of giving it, even in autoimmune encephalitis, we do the CSF IL-6, it comes normal. So it's a real problem.
Okay.
So I'm not sure.
Because for me, it's the other way around. So maybe it's these patients that you worry about don't have it, because I sometimes do it on the normal ADEM and they all have raised IL-6 and they're fine with steroids. So it's interesting.
So I've done in quite a few because it's easily available. CSF IL-6, we sort of do it anyhow in all our ALREDs.
Exactly,
and,
exactly.
So, like acute leukoencephalopathy, restricted diffusion, the concept should be that there should be a storm, cytokine storm. Same with this patient who deteriorated, IL-6 has been normal, except one patient of fires who had a high IL-6.
Yeah.
But
Fires,
they-
I never even know what fires is. But I do it a bit like you when children, they come to us and they get CSF, and I have quite a few patients with normal ADEM without, life-threatening cerebral edema that have raised IL-6. So you wonder about the mechanism. That actually may not be cytokine-mediated mechanism in this one. If in some of the ADEM we get it, but also IL-6 can work in more than one mechanism, I think so.
Okay, it was great to know that, I mean, people have done craniotomy as a part of treatment. Just wanted to know if there is any role of plasmapheresis in this situation, because that will be more as compared to any other mechanisms for medical management. That also would have a quicker action, I suppose.
I use Plex a lot for MOG, much more than, and I think we should use it more than we do, because I wonder if even if you Plex early, you reduce the risk of relapse in the long term, and you can come off the steroids much quicker. There's also a nice study that John Chen from the Mayo is now, I think he has 250 patients that we're looking at the response to Plex. It's definitely better than IVIG in the acute setting. And I think there's now a shift into like trying to come off steroids quicker, and things like Plex, should be used. So I think with this life-threatening, as Professor Udani said, really neurosurgical. But if you have a patient who's very encephalopathic and you're not seeing much improvement after a couple of days of steroids, I would go for Plex. And if I see patients who are blind or completely paralyzed, I will sometimes even Plex around the same time as the IV methylpred.
Okay, because here, I mean, the timeline was really very tight. I think very close to 48 hours, this child deteriorated from the time he came to us. So, I mean, I think we couldn't even give him third dose of methylpred. By then, he had already signs of significant raised ICP. So, yeah, at that point, actually, we gave tocilizumab after like close to 48 hours from the time he came to us.
I think the learning which I had from that patient and from this one is
Surgical.
those few hours of indecision, that few hours of dilemma where whether you counsel the family and go for something big like bilateral frontotemporal cranectomy, because the thing is we are hesitant, because before that patient I had never done it, because I thought how will it work, but because it worked in that patient, I would say and suggest that we should in those few hours just go for it.
Sure.
Yeah, I second you completely, Vivek. Yeah.
Okay, I mean, next time we would definitely consider this probably. But yeah, it was always it is always a dilemma, and actually the things happened in the middle of night. Unfortunately, we were as a neurology team, we were not communicated, and we knew about the deterioration only like 5-6 hours down the line. So, and that was also a thing. But yeah, I mean, once somebody has some experience, then we will be more comfortable doing the similar things, adding on to experience as well. Sure. Thank you, Dr. Vivek, for your inputs, and yeah, all of you for your inputs.
All right. Thank you, Dr. Nikit,
yeah,
for your teaching case.
Yeah. Thank you.
All right. Now we move to the Northeast. Devangna, if you're there.
Yeah. Yes, sir. So this is a 3.5-year-old male child who was born of a non-consanguineous parents. Initially, the parents said that it was normal birth and normal development. But the child presented to us with febrile status epilepticus. History of fever was there since 1 year back. On and off fever was there, for which they had been taking some Ayurvedic and homeopathic medication from outside, which was stopped 1 month back. Now he presented to ER in the middle of the night with multiple episodes of multifocal clonic seizure. So initially started on all the medication, but seizures was controlled only with injection methylprednisolone infusion. Then parents gave history that the child had generalized weakness since last 1.5 months and was not able to walk since last 1.5 months. Also, the child was born normal with fair skin. However, parents noticed that after around 2 months, the child had some skin changes. The child had severe hyperpigmentation of the entire body, and also and the hair was hypopigmented. Also, for a 3.5 years old, the child was cachexic with weight of only 12 kg for 3.5 years, and on examination had lymphadenopathy, and the spleen was very much enlarged with, it was a stony hard spleen. So initially it took time for the status to get better, and so we had planned for a MRI the next day, but by the time the child had deteriorated, and in the morning the pupils were already fixed dilated and pulses were very feeble, but somehow we could get the MRI done. So can we discuss the MRI first and the reports?
All right. Okay. Anything on the video for the radiologist?
Multifocal chronic seizure the child had on presentation.
Okay.
That's it.
All right. Okay. Okay. So MRI at the stage where child had already, I think, was in a very bad state. So non-contrast T2 sequences, we have multifocal abnormalities involving the gray matter and white matter structures more on the left parietal frontal lobes. You can see the left frontal lobe, the subinsular region, the external capsules have these hyperintense changes, edematous changes. The deep brain nuclei has these multifocal abnormalities. And then you have uncal herniation on both sides, particle edema, brainstem and cerebellar edema. The sulcal spaces are completely effaced. And the SWS sequences, we can make out that there is prominence of the transcerebral and the medullary veins, bilaterally diffuse stasis of the cerebral veins on both sides, supra and infratentorially. I don't have a diffusion scan, but the ADC sequences with the abnormalities which we have seen demonstrate vasogenic or facilitated diffusion, especially in the frontal lobes. It's a contrast. The T1 flare sequence did not demonstrate any enhancing abnormalities. Then, as Devangna has mentioned, the lymphadenopathy contrasts the spine. You can appreciate bilateral cervical lymphadenopathy. There is, you can see that diffuse herniation, tonsillar herniation out there. The child is, almost in the state of. Then you can then you have multifocal abnormalities in the spinal cord. On contrast, you have this focal abnormality in the cervical cord. Post contrast, you at least had at least 3 or 4 lesions in the intermedullary region demonstrating this nodular enhancement. On contrast, T2, I think you have this focus of hypointensity, possibly suggests to some hemorrhagic changes or hemocytin foci on the axial sequences. So the venous, the SWA changes, what we see is due to increased, possibly due to increased oxygen extraction and deoxyhemoglobin in the capillary in the veins. It's a common sign or indicator of severe prognosis for the child. And then on the imaging findings, based on the systemic findings, we thought of an initial possibility of HLH, given that the brain changes and also spinal cord abnormalities with lymphadenopathy. This was a primary consideration. Lymphomas was also considered, but we are thinking of primarily of HLH-related changes. I'll open the case now if anyone has any further suggestions. Sorry, Dimang, if you want to just complete the lab.
Yes, a blood picture hemoglobin was 10.7 with total count of 4,000, with lymphocytes of 49, neutrophils of 37%. ESI was 30. He had CSF showed 5 cells which are all lymphocytes. Sugar and proteins were within normal limit, but he had raised ferritin. Ferritin was actually 549.4. LDH triglycerides were also increased. But however, we could not do bone marrow biopsy because the child had died within 36 hours of admission. So before we could get time to do bone marrow biopsy. However, maybe possibly secondary to infection or malignancy, but not sure about the skin changes. Yeah, so could be possibly, but not sure about the skin changes and the pigmentation which he had. We got a dermatology opinion, but they also could not give. They were also not sure what.
Hypopigmented hair, HLH is sort of Grizzly syndrome.
Grizzly, yeah.
It was hyperpigmentation, so not hyposome.
Can I ask a question?
The hair, yeah.
Or hair was hypopigmented.
Yeah, no, sorry, Dr.
Sorry, I just want to, looking at this patient, the first thought which came to my mind was Kala Azar. Did you get HLH with Kala Azar?
Yes, sir, we got their LD bodies done. It was negative, sir.
What about heavy metal poisoning? Any question with Ayurvedic stuff going on from here?
Okay, so could be because of he was on some medication since 1 year on and off.
Because his brain changes are not explained.
But these changes happened at 2 months of age, sir.
2 months of age?
Yes, the skin pigmentation and those hair pigmentation had happened at 2 months of age.
The child have any organomegaly in liver and spleen?
Spleen was enlarged.
Massive sphenomegaly.
That should be Grizzly then. It should be Grizzly then.
Yeah, Grizzly also has a possibility. Yes.
Okay, so I have a sample which I can send for immunodeficiency whole exome. I can send for, sir.
Yeah.
Okay. Thank you. Okay, thank you.
Okay, Debangna. Yeah. Okay.
This is 3 months old child, 3.5 months, born of IVF pregnancy. It was near-term delivery at 35 weeks. LSCS, birth weight was around 3 kgs. Except for cleft lip and palate, the child was otherwise fine. So he was discharged on around 5th day of life. Then he presented to ER at around 15th day of life with respiratory distress requiring oxygen support. For which he was initially admitted in an ICU for 15 days and gradually the oxygen was weaned off and the child was discharged. Again, within 2 weeks, the child again presented with poor feeding, lethargy with query aspiration, for which this time he had a prolonged ICU stay for around 1.5 months in the NICU. During the NICU stay, sisters noticed that child had multiple episodes of staring look or some or focal movements and also some clonic movement of either upper right side or left side, for which the seizures were controlled with levetiracetam and phenobarb. Investigation wise, CSF was done, which was normal. Otherwise, there was no signs of any infection or cultures were negative. Because of seizures, we got an MRI done at around 3 months of age.
Okay. Yeah, on top of diffusion, no signal acute abnormalities on the diffusion sequences. The flare sequences, you have these multicystic changes in the periventricular and deep cerebral white matter on both sides. Reduced periventricular white matter volume, There's no significant ventricular, but I can appreciate that the volume is significantly reduced. Do not appreciate any structural changes, at least on these scans. But if you see the posterior fossa, the cerebellum is slightly hypoplastic, and there is prominence of the extractile space out there. The T2 sequence, again, you can appreciate these multi-cystic changes in the periventra deep wide matter. Here you can see that the atria is slightly more prominent on either side. Structurally, I cannot again appreciate any abnormalities. The cerebellum, especially out here, you can see that for a 3-month-old, I would consider that slightly hypoplastic. The vermis is also reduced. There's some degree of inferior vermin hypoplasia. Pons also maybe marginally is hypoplastic out there. And corpus callosum, I would say, is again slightly thinned for a 3-month-old child. There is prominent cisterna magna. SWS sequences could not appreciate any mineralization or hemorrhage or hemosiderin deposits. Based on that, I think 2 considerations were thought of. One was the cystic PVL, which can have these white matter changes, but only the thing was that the posterior fossa abnormalities are not that common in a hypoxic ischemic child. Then we thought of maybe a HI mimicker such as Col4A12 mutations, which can have these cystic changes. But the characteristic calcification hemosiderin was not seen in our child. I'm not sure of the slight thickness, but that was not seen at least in our images out here. Posterior fossa can have some degree of hypoplasia. So these 2 possibilities were considered. And then I think, so we had 2 variants of uncertain significance.
Yeah, we had 2 variants of uncertain significance, but he was based on the brain MRI, we can say that he was matching Col4A2. But for the clinical features, I'm not sure because he's very young now, 3.5 months of age.
But there was some degree of aspiration and respiratory difficulty, at 35.
Yes, sir, some aspiration and respiratory distress. Other than there's mild spasticity had set in now, but otherwise, other than that, we need to maybe wait and watch. Yeah. So with progression of the disease, we need to wait and watch.
Yeah, I'll open the case if anyone has suggestions, whether it's an acquired cause or a genetic cause.
I have a question and a comment. My question is, did you measure lactate or pyruvate? And my
yes, sir. It was lactate and pyruvate was normal, and newborn screening was also normal for this child.
I have seen a rather similar patient with also posterior fossa changes, the clinical situation comparable, and periventricular cysts. And this was, in retrospect, interpreted as energy failure leading to tissue breakdown, and genetic investigation revealed a mutation in the pyruvate dehydrogenase complex. This is an X-linked gene complex, and this is, although this is a boy, this is an option, I think. PDH.
Would you consider molybdenum too? But they are usually more peripheral, I guess. Sulfide oxidase molybdenum.
So you can perhaps go back to the geneticist and ask whether they have any evidence for this. They can reanalyze the data.
Okay, sure. I'll do that.
What about congenital infections? This doesn't fit in, Dr. Nihaal?
No, it doesn't fit in, Dr. Rashmi.
Which way?
You're thinking of CMV or?
CMV is what I think. Yeah.
They're usually more peripherally abnormality, subcortical cyst malformations. Periventricular and deep matter is not typically involved. I mean, classically involved.
Okay. Thank you.
Some degree of calcification also. So, would you do a parental testing, Devangana, now, or for the genes?
Maybe after reanalysis of the report, then I will go for genetic parental testing.
Okay. If anyone has comments of if it's only acquired cause or not a genetic one, but the posterior fossa structure is slightly abnormal for only an acquired cause. That was the only pointer I had.
Was the baby premature or was?
Yeah,
35 weeks. And IVF pregnancy.
Cerebellar disease has been known in this in prematurity.
Yes.
There is sort of an encephaloclastic kind of, so you get cystic changes and all. This is of course just a warning process.
Yeah, voluminous, and there was no hemosiderin to suggest any perinatal insult. I mean, that is usually a marker which we see.
It's not, I mean,
Yeah, I
it
know
can
it's
be
not a.
prenatal.
Yeah. Usually there is some degree of you have some blooming on the SWIs, even in the antenatal ones. But question of call for a can have cysts without hemorrhage. Yeah, that was the only the point which we did not have supporting call for a.
For me, for collagen, it's too symmetric.
Yes.
And it's only, well, only in quotation marks, supratentorial, periventricular, and not in the brainstem or in the cerebellum.
So what would you advise? I can reanalysis of genetics and check for mitochondrials and parental testing.
Mitochondrial in the broad sense. And again,
I got it.
Ask the geneticist to look at the PDH complex.
Yes.
Okay, sure. Thank you.
Okay. Okay, I think last two cases, Anas.
So it's a 15-year-old child, second in birth order, born to third degree consanguineous parent. So initially she was evaluated outside. So she had fever for 1 month initially with cough, cold, and increased work of breathing, for which she was evaluated at TB hospital where X-rays were done, which showed bilateral pneumonia. CBNAT was sent, which was positive, and ATT was started. So despite using 1 month of ATT, her fever and cough, cold, and tachypnea persisted. So she was brought to our ICU. So outside she was evaluated for fever. Her ESRs were high, 140, CBNAT positive. She had multiple lymph nodes. So CT scan was done for as part of the evaluation outside neck, chest, and abdomen, which showed inguinal as well as cervical jugular-digastric lymph nodes. Lymph node biopsy was done, which was negative for TB or malignancy outside as well. When the child was admitted here, again she was evaluated. Lymph node biopsy as well as bone marrow, both were repeated. And gastric aspirate was CBNAT was sent, which were negative. Thing is, when she was brought here, she had pancytopenias, which persisted throughout, and there was no improvement despite using ATT. There was marked derangement in LFT, SGOT was elevated. So after consultation with the infectious disease specialist, she was shifted over from the regular ATTs and shifted to the renal renal excretory ATT. As part of evaluation, ANA was sent, which was positive, and dsDNA was positive as well. Because of pancytopenia, she had also mucositis, this hair loss as well. So suspicion of SLE was considered, and she was started on immunomodulation. She was started with steroids initially, and then MMF as well as HCQ was started. So she was under PICU care because of the multi-system involvement. There was no initial CNS involvement. So by day 10 of the hospital stay, she became encephalopathic, and so ICU was involved, neurology was involved. Based on the encephalopathy and multi-system involvement, MRI was ordered.
Okay. So here we have the MRI diffusion on top. Some focal abnormalities in the left parietal cortex out here. The left parietal white matter, you can see it over here again, an area of diffusion, a change. A more confluent abnormality involving the left temporal lobe extending up to the central regions of the posterior limb capsule, the thalamus out there, the peritrigonal region. So the entire temporal lobe is demonstrating this confluent abnormality. White and gray matter structures are involved. On the ADCs, some degree of the central degrees have this area of restricted diffusion, whereas the temporal lobe, the white matter chain is predominantly demonstrating facilitated diffusion. The cortex has some degree of restricted diffusion. A mixed pattern in the confluent abnormality out there, and also mixed pattern in the focal changes with central cytotoxic edema and some degree of pathogenic edema. along the central aspect and also on the periphery. Some degree of midline shift because of the temporal lobe lesion. Flare sequences, non-contrast. Again, you can appreciate the multifocal abnormalities and the confluent abnormality out here. There was some thin subdural collection along the left hemisphere. Post-contrast, sorry, this is non-contrast T1. So non-contrast T1, you have some areas of T1 hyperintensity, possibly demonstrating particular laminar necrosis. And the SWA sequences had these punctate foci of blooming, likely suggestive of hemorrhagic foci. In the multifocal abnormalities in the parietal lobes, there were also punctate foci in the temporal lobe lesion. The cortex, which demonstrated T1 hyperintensity, did not demonstrate any blooming, suggestive of that they are not hemorrhagic, but possibly necrotic. The sagittal sequence demonstrate generalized reduction in the brain volume. Calvarium is slightly thickened, especially the clivus out here and the frontal bones. But other than that, corpus callosum again demonstrates some degree of mild volume loss. Post contrast, there was minimal enhancement, not very uniform in the parietal lobe lesions. Some degree of leptomeningeal enhancement in the left hemisphere, as you can see in comparison to the right side. You see over here there is some degree of enhancement, some pachymeningeal enhancement out there, and there is some gyral enhancement demonstrated on the temporal lobe abnormality. So based on the clinical presentation and the encephalopathy of the SLE, multifocal abnormalities have been demonstrated in SLE, which can present with demyelinating lesions, vasculopathies, vasculitis, and the focal abnormalities, especially the parietal lobes, which had also had some possible hemorrhagic foci, fungal etiology also to be kept in mind. And as a child had pancytopenia, I think immunodeficiency status, I think fungal might be a good consideration. So we are working with diagnosis of CNS changes of SLE and possible infective changes, predominantly fungal etiology. So Anas, is there I think there was a follow-up done.
पार्किंग डाल दो क्या जाएंगे ऊपर
Anas, go ahead.
Yes, sir. So initially, when we saw the report, the discussion was fungal versus is it just CNS vasculitis from the SLE, or there's a fungal component as well? That was the main debate because child was already by the time being treated for with immunomodulators, and so at that time, so the debate was among these two things, and again to do lumbar puncture or not, considering the cerebral edema. So at that time, I think initially LLP was deferred, and later as the child was becoming sick, and again possibility, I mean, discussion was also made to go for neurosurgical intervention to get a biopsy. That was another consideration. After discussion with parents, it was decided that we'd go for CSF analysis, CSF to see if it will be positive for any fungal. And so I got a report from the ICU team that I mean now the child has expired a week ago because of the multi-system involvement. But we got the report for fungal spores, PCR detected fungal species. And genetics was sent earlier, and which we got it, but it was unconclusive. Discussed with the geneticist regarding chronic rhamnoid disease. The child was evaluated for immunodeficiency outside in the previous hospital. DHR was normal. Immunoglobulin levels were normal as well. IgG was elevated, but lymphocyte subset analysis is normal. And this is genetic report. Otherwise, prior to this, child was a well-thriving child.
The main question: any alternate possibilities, or what is the?
So the main question
discussion?
is, the main question was what regarding role of biopsy, role of LP, and what to do at this juncture when the child is already receiving immunomodulation and then suspicion of fungus is there. Child was started on amphotericin B and flucytosine when after the report, but that was the main concern to go ahead because there's immunological wise, ANA was positive, dsDNA was positive, cell lines were decreasing, as well as there's a pleural effusion cardiac dysfunction, high ESR. There are multiple features favoring SLE. But and the background child also had one CB note of TB positive earlier in the previous hospital, which was not replicated here.
Okay. Yeah, I'll open the case for any comments.
This looks more like a aspergillus, right? Because of the vascular. Just wanted to know if amphoby and flucystin are better here or it's more voriconazole and capsofungin. It's just, does it cover aspergillus well? And how did we explain the CBNAT positivity for tuberculosis? That was confusing.
Yeah, so it was done when maybe a month earlier before they had come, and the child, based on that, the child was started on ATT earlier at the TB hospital. So they were started on ATT, and then when the results were not replicated, lymph node biopsy was sent as well as multiple gastric aspirates were sent, and we never got the CBNAT positive again. So that was another confusing thing in this case.
So it's just why I say that, because there was a patient I had who had similar CBNAT positivity and did not have tuberculosis because the culture didn't grow it later. And then we explored this further. When these are done in government hospitals, sometimes it needs robust cleaning so that the previous sample evidence is not there. So, sometimes the technical error causes the positivity of the CBNAT because of the way it is done. And CBNAT, I think, only picks up dead cells. It could still be dead. It doesn't tell you that it's an active TB infection. It is just that there was probably a TB mycobacteria in the child at some stage, but it is not foolproof. So due to technical issues and also the interpretation of this test, because I had a similar experience with a patient who didn't have TB, but his actually CSF sputum CBNAT was positive, but the child didn't have TB. And the question about Nihaal, does it look like aspergillus more? Because it doesn't look like cryptococcus or candida. Very.
Yeah, definitely not cryptococcus.
Toxoplasma, is that a possibility?
I wouldn't consider here toxoplasma. Enhancement is certainly atypical.
Okay.
And only, I mean, they usually have central involvement, but yeah. It is a question of CGD with encephalopathy. Yeah, CGD.
Yeah, patient was pancytopenic throughout the.
Yeah, patient was pancytopenic. And the role for biopsy, anyone? If they are considered biopsy for the lesion or?
Just a question, the biopsy is being done to rule out fungal, right?
Yeah. Yes, that was the main thing.
Yeah, so the question is that
LP would help.
Yeah, in fungal, you usually don't get any restriction of diffusion at all. Is that odd, or you don't think it's because this has been going on for a while, and you have a ring enhancement kind of peripheral enhancement, but apparently there is no. You said there was no diffusion restriction. Am I right?
No, there is mixed, Dr. Udani. If you see these low signal areas over here on the ADC, I meant that the temporal lobe, the white matter has predominant facilitated, but these lesions are demonstrating some degree of diffusion. But the CSF, is that definitive for the fungal?
It just detects the PCR.
PCR, sorry, okay.
That's a metagenomics, right? That's from metagenomics, right?
Yes.
Yeah. And Nihaal, is it? It's just for the fungal type of infection, looks more like a aspergillus, right? If you have diffusion restriction, sorry, not diffusion, SWE image which shows these blood
blooming foci, yes,
blooming foci with such a lesion, because voriconazole is always has a much better effect than amphoby if one thinks of aspergillus as a possibility. Yeah.
Yeah, I would say aspergillus is a differential. It's histoplasma and aspergillus, not cryptococcus. Those are more focal lesions, at least, which I know of, the fungal ones.
Cryptococcus will be more basal ganglia and
yes,
yeah,
yes,
base of Virchow.
and more leptomeningeal inflammation for cryptococcus. Sorry, yeah.
The child had died, right?
Yeah, unfortunately, I think most of our cases today have succumbed somehow.
Yeah, I mean, that's okay. But I would, was the child on voriconazole?
Anas?
Anas?
Not today.
Only on
Sorry?
Amphotericin and flucytosine.
Okay.
So I think takeaway would be biopsy may not help, and
yes, maybe voriconazole would have helped.
Voriconazole would have been better.
I think ampho and flucysteine best for candida and cryptococcus. Voriconazole really good for aspergillus, sort of, if we are thinking that.
Okay.
Thank you.
All
Thank
right.
you.
Thank you. To our last and possibly most interesting case from Dr. Udani. Sahel, if you're there, if you want to present the case.
Yes, sir.
Yeah.
So, he is an 8-year-old boy. Around 3.5 months back, the history started with a fever for 3 days. Following that, there was a right-sided focal status epilepticus on day 2 of fever, and that resolved by single anti-epileptic only. And he was normal within 3 hours, and after that, there was no neurodeficit. So he was discharged in 2 days and was asymptomatic at home. However, as a part of workup for that status, MRI was advised, and for some reason he got it done after 3 weeks. So this was done outside. This all was happening at an outside center. So first MRI was done at this time.
Okay. Yeah, again, another confluent lesion out here in the left hemisphere involving the white and gray matter structures, some degree of diffusion changes, predominantly facilitated diffusion, but the cortical regions and some focus within the abnormal white matter has restricted diffusion. It is a predominantly left frontal lobe abnormality, also involving the deep brain nuclei, the thalamus, the basal ganglia out there. Better appreciated over here on the T280 sequences. You have these confluent abnormalities involving predominantly the white matter structures. You have these multiple punctate foci extending up to the parietal lobes and the contralateral side. Deep brain nuclear involvement is seen. The central white matter also is demonstrating these hyperintense changes. Brainstem also is involved. The midbrain out here on the left side, the left half of the pons, with some degree. Yeah, so as predominant changes on the left frontal lobe, also on the right frontal lobe, the deep brain nuclei, central structures, and also the brainstem. Rare sequences, again, same changes what we have seen on the T2A sequences. Again, confluent abnormalities on the left hemisphere than the right. SWA did not demonstrate any focus of hemosiderin or mineralization. Post contrast, we had these multiple punctate and nodular enhancing foci within the confluent abnormality on both sides. Again, you can see, the coronal sequences better demonstrate the contrast uptake. More subcortical confluent enhancement and these multifocal punctate abnormalities in the abnormal white matter and the gray matter structures. Spectroscopy was done, which demonstrated a significantly elevated choline peak. The rest of the peaks are significantly reduced. There's possibly a lactate peak out here. And then, Sahil, over to you.
So based on this MRI, a CSF study was done, and it was basically normal apart from 1 to 3 oligoclonal bands. So suspecting demyelintic pathology, a patient was started on IV methylprednisolone. Within 5 days of that, he developed right-sided hemiparesis, and which was gradually progressive in nature, involving starting from the hand and then progressing to the leg as well. Also, it was associated with gradually progressive psychomotor slowing, slowed speech, and drowsiness. This was also associated with right-sided esotropia and left-sided ptosis. All this developed over few days, gradually progressive. So at that time, in the diagnostic dilemma, brain biopsy was done. That was also done at outside center. and it was suggestive of inflammatory demyelination. At this time, patient had come to our hospital for further management, and we repeated an MRI. By this time, patient was around 1 month later. So 1 month after the initial MRI, we had repeated the second MRI.
All right.
Because many
So,
symptoms are
so yeah. So follow-up MRI, there is progression in terms of imaging. You see the right side is more significant abnormalities, the frontal lobe, especially out there. Also, the left changes, the left hemispheric changes remain, whereas the deep brain nuclei now more lateral involvement of the thalamus. The brainstem structures also demonstrate progression in terms of the involvement of the pons and also the medulla, and there is some degree of volume loss, cortical volume loss. So interval scan demonstrates interval progression on both sides, supra and infratentorially. Diffusion changes, there was some rate of restricted diffusion, especially in the central structures, the coronal radiata out there, the posterior capsule, the thalamus, the brainstem structures also demonstrate restricted diffusion. SWA sequences, I think these are biopsy changes, but other than that, we cannot appreciate any focus of abnormality in the white matter changes or the confluent changes in the frontal lobes. Some mineralization, possible mineralization out there in the globus pallidus on the left. Post contrast, again, you have these multiple punctate foci of abnormalities now in bilateral hemispheres. More, again, you can see the spread on the right side. And yeah, so overall progression in terms of imaging in the supra and infratemporal brain. Spectroscopy again demonstrated a similar picture, elevated choline peaks to the lipid lactate peak, the lactate peak out there, and reduced NA and creatine peaks. A spine study was also done. Spine did not demonstrate any focal or long segment abnormality. I don't have a contrast image of the spine, but this is just a T2 sagittal sequence. I think this is the radiological differentials
So based on this imaging, the radiological differentials were like first there was a query of whether it is HLH, but all the HLH markers were negative and CSF didn't show any hemophagocytes. By bone marrow, brain biopsy, everything ruled out HLH. Infection was also another probability, and one supporting feature was elevated protein, but rest everything was normal, and biophase was negative. Malignancy was the third probability, but that was again ruled out because of the bone marrow and CSF not suggestive of any atypical or malignant cells. And finally, because of the presence of elevated protein and oligoclonal band in 1 to 3 number, and ultimately the brain biopsy also suggestive inflammatory demyelination, we went ahead with the provisional diagnosis of tumefactive demyelination, and child was, because of the aggressive course, a child was started on plasmapheresis, basically.
All right, then, sorry.
Yeah. So after 4 cycles, however, yes, I will just tell this. However, after 4 cycles of plasmapheresis, he started developing periodic jerks. This was totally new symptom that the child developed, and we did an EEG at that time, video EEG, and this showed like high amplitude delta discharges correlating with the jerks. So we thought whether is it SSP. So SSP for CSF was tested for SSP 2 times, and both times it came out to be negative. Now then we started looking at digging deep, and we took out all the previous records. And then we saw that for many years, he had been having this waxing waning neutropenia. And also one previous report showed low immunoglobulin G levels. Other immunoglobulins were normal. Lymphocyte subset analysis was normal. HIV was negative. And at this time, suspecting some immunodeficiency, we sent the genetics also. And we reviewed the brain biopsy. And this time, the brain biopsy was suggestive of CMV encephalitis. The same specimen was reviewed at another center, and it was suggestive of a CMV encephalitis. So we started ganciclovir, and he received around 2.5 weeks of ganciclovir treatment as well. But he was not improving. Rather, he developed new symptoms, and he started having excessive drooling, so much so that he couldn't maintain his own airway and had to be intubated because of the excessive secretions. And at this time, MRI brain was repeated again 1 month after the previous MRI.
All right. MRI brain, similar story. Again, interval progression in terms of the imaging findings. Now you see that the deep brain nuclei on the right side are more severely affected. The brainstem structures are more severely affected. There is extension into the temporal lobes on the left side, parietal lobes. It was not previously seen. So imaging progression over a period of 1 month on both sides. Now the brainstem is more severely involved. Again, stepwise sequences other than the possible mineralization in the globus pallidus did not demonstrate any focus of hemorrhage or hemosiderin or mineralization. Diffusion weighted sequence again had similar changes. The deep brain nuclei has some degree of diffusion restriction, the central white matter, and also the brainstem structures. Post contrast, again, we have similar pattern of enhancement, slightly less in terms of intensity, but these punctate enhancing foci are also demonstrated on both sides, also involving the brainstem structures. So just to highlight, I think that's the last scan I have. Just to highlight the progression of the changes. In October, we had more predominant left hemispheric abnormalities and slightly left brainstem structures involvement. Whereas in over a period of 2 months, you can see that there is progression in the imaging findings, even though the child was on multiple medications. So imaging find now the right hand hemisphere also is demonstrating these confluent abnormalities and more infratentorial involvement. Based on that, we thought of a case of GFAP. I think Dr. Vivek is there. Maybe he would like to highlight the imaging findings, but we have similar findings on a GFAP case from Dr. Vivek. Confluent abnormalities, they usually have perivenular enhancement. This had more confluent enhancement. That was an imaging consideration based on these findings. SSP, I think, was ruled out, but we also had a atypical case of SSP with confluent abnormalities, cystic changes, refractory changes. This was a case from Dr. Divyani, to discuss in our forum previously. HLH, again, given that the child had the imaging progression and these changes over the palatal hemispheres and infra and supratentorial brain, and the enhancement pattern, which can be seen in some case of HLH, which was seen in also in our case, that was a consideration on imaging. Then PML, these are examples of imaging examples of PML. Again, can have multifocal abnormalities, typically not associated with CMV, at least not seen any cases with CMV. JCV virus is more commonly seen with PML-related disorders. So imaging considerations were these, and Saheli, if you want to just give us the final diagnosis or probable diagnosis.
Can I share one slide?
Yeah, sure.
Yeah. Okay. So I can.
Sorry. Can you share the slide?
No. So then I will.
No,
I can. Yes. So the final diagnosis was based on a review of slide. It was reviewed and it was suggestive of JC virus-induced progressive multiple leukoencephalopathy with typical inclusions in the oligodendrocytes with immunohistocytochemistry staining for the JC virus as well. Following this, we sent the CSF for JC virus PCR and it came out to be positive. In the meantime, whole exome sequencing also came and the report came and it was suggestive of hyper IgM syndrome. So the entire puzzle was solved and it was final diagnosis was JC virus induced PML in a case of hyper IgM syndrome. We searched the literature regarding what treatment can be given for this and based on the literature review, basically for the hyper IgM, he was started on the IVIG and cotrimoxazole prophylaxis, and for the JC virus infection, he was started on pseudophobid injection. So he has been given 2 doses and he has discharged on home BiPAP, currently planned for long-term pseudophobid, but it takes time to work, so we have to wait.
Yeah. Thank you, Saheli. I'll
Do you
open the
have-
case now. Sorry, Dr. Zani. Sorry.
No, I just think it was a problem was that the brain biopsy led us astray twice. The first biopsy felt very clearly it was a tubifactive inflammatory demyelination. And then later on, the second review showed that the antibodies to CMV were actually positive. They found some inclusions, and the inclusions were positive for anti-CMV specific antibody. And I was, that by that time we were convinced that this is a very atypical CMV, but with the antibody being positive, what else can it be? And we gave cyclovir, unfortunately, it actually worsened. She forgot to mention that we did give IVIG in the middle, because there was the low IgG, which was found in the previous reports. But apparently nothing really helped. And I mean, I think prognosis is generally going to be very poor in this.
Very wonderful case, actually. Very interesting. Actually, we have also seen atypical CMV. I mean, it didn't turn out to be that now, but we have seen very atypical ones, really bad and florid also. So yes, could have been, but it's a really great learning from this case.
Have anybody seen PMLs in children commonly? Because I know it's highly associated with HIV, but even in HIV, you don't see JC virus very commonly in children. PML.
So, literature search, Dr. Udani, I could only find maybe 10 cases. I think this is from a report from 2017. It's a non-HIV related children with PML.
Right. So hyper IgM syndrome actually does have PML as well.
Yeah. So there is one case here with hyper IgM syndrome as of 2017. So yeah. But yeah, we have not seen. I mean, at least in the last 2-3 years, I have not seen any PML cases.
Anybody has any other comments? I mean, because okay.
Dr. Vivek had mentioned GFAP. Yeah. Dr. Vijay.
The GFAP patients, the two I had, they had disproportionate MRI changes, but clinically they are quite well. So, and they respond really well to steroids. So, worse MRI changes than the clinical presentation. Sir, where did you do the JC virus? Where do you CSF?
No, we did the JC virus at Metropolis and review of the slide from Niman's. And they finally, there's no question about it. They give me an immediate diagnosis. So I really think that, because there's a real dearth of neuropathologists in the city, in the whole country, in fact, especially in the private sector, and you really have to depend a lot on on government hospitals in this. Okay. The reason for brain biopsy was actually not done by us, but the first diagnosis at that time was thought to be a glioma, because it was mainly on the left side and there was a kind of expanding or whatever, and therefore they suspected a glioma and they went ahead and did a biopsy. Or maybe it was a differential between a demyelination and a glioma, and it came back as a demyelination. So obviously, things got a little out of whack after that. Thanks.
Thank you, Dr. Udani. Yeah, I think it's a great case to wind it off.
Yeah, thank you.
Thank you. Thank you very much. And that is the last case. Thank you once again.